I am Dr. R.K. Goyal, Senior Professor and Consultant, Maharaja Aggarwal Medical College, Aggarwal. Today we will be discussing asthma, chronic obstructive pulmonary disease overlap. What is new? First of all, coming to the basic definition of asthma and COPD. Asthma is defined as chronic inflammatory condition characterized by shortness of breath with cough and wheezing. Then chronic obstructive lung disease is having two parts, chronic bronchitis and emphysema. Chronic bronchitis, as all of you know, chronic bronchitis is defined as cough for 3 months in a year for 2 successive years. Then emphysema is defined as permanent dilatation of tracheobronchial tree, distal to tracheobronchial tree, distal to bronchioles. So the total is chronic obstructive lung disease. Now coming to introduction. Aegis is a heterogeneous condition describing patient with persistent airflow limitation and clinical and inflammatory features of both asthma and COPD. Aegis means asthma, CO means chronic obstructive lung disease. Asthma and chronic obstructive lung disease have unique clinical features. Nevertheless, these clinical features can coexist, making it difficult to distinguish between the two conditions in a clinical setting. As a result, the term asthma COPD overlap was introduced. However, despite the increased research interest in echo, there is still much controversy about its existence as a distinct entity. And from 2020, the Global Initiative for Chronic Obstructive Lung Disease, GOLD, stopped referring to echoes, emphasizing the absence of a universally accepted definition due to the lack of substantial evidence. साफ नहीं आ रहे? Yes. In 2017, the American Thoracic Society and the National Heart and Lung Blood Institute collaborated on echoes workshop report. The panel concluded that the echoes, like asthma and COPD, does not represent a singular unique disease entity. So there is much confusion whether asthma and COPD are combined or they are separate. There is still confusion and they are overlapping. So instead, echoes should be utilized to describe patient with a prolonged history of asthma, a modest smoking history. Smoking is very important for causing asthma and COPD, and fixed airflow obstruction. Concurrently, those who exhibit asthma-like symptoms such as peripheral eosinophilia, this eosinophilia is also very important, and bronchodilator responsiveness may have echoes. While both patient groups are clinically and likely pathologically unique, they are both within the purview of echoes. However, in 2021, GOLD report that term echoes no longer exist, and the authors state that COPD and asthma are two distinct entities which can coexist in a single individual. It means some people say asthma and COPD are combined same. Many people say asthma and COPD are different. Some says there is an overlapping of asthma and chronic obstructive lung disease. Despite the removal of echoes from the most important reports on the management of asthma and COPD, GINA and GOLD, this entity still continues to be an important and burning topic in the science. Definition: a number of authors and different consensus guidelines have proposed various definitions of echoes during the last decade, usually using several major and minor criteria. Most of them emphasize the heterogeneity of clinical features and function and lab findings that should be considered as diagnostic criteria that could apply for the identification of individuals with possible diagnosis of ACOL. According to Dutch hypothesis, obstructive airway disease share a common genetic pathway. This is very important. Dutch hypothesis, genetic pathway is very important, which says bronchial hyper responsiveness being important in both asthma and COPD, while environmental factors determine whether one would have asthma or COPD. This could be differentiated from British hypothesis provided in 1965 by Charles Fletcher, who proposed that an individual with certain genetic predisposition may present the clinical phenotypes of COPD and asthma after exposure to smoking and antigen sensitization. So 2 points are important. One is smoking, second is hypereosinophilia. The most accepted ACOS definition is now one of 2015 Ginna and Gold documents. In this report, the patient should have a chronic airway disease, means a medical history of cough with sputum production with wheezing or repeated lower respiratory tract infection. So the 4 points are very important. There should be history of cough, there should be history of sputum production, there should be history of wheeze and lower respiratory tract infection. Then wheeze means asthma, cough with expectoration means COPD. If these 4 features are there, then we can say label it as ACOS. Epidemiology. The prevalence of ACOS in overall population is only 2 to 3%, whereas the prevalence of asthma and COPD ranges from 5 to 17%, means asthma is 5 to 7% and chronic bronchitis is 2 to 12%, much higher than the 2 to 3% of ACOS. However, in COPD patient, the prevalence of ACOS may be as high as 25%. And in asthma patient, the estimated prevalence of ACOS ranges from 10 to 31%. Means in asthma, it is much higher as compared to this COPD. In 2023, the lower airway infections were very common, and there was very much respiratory infection, mainly the Provitella and Streptococcus, Haemophilus, Pseudomonas and Moxella. These bacteria were causing lower respiratory tract infection in ACOS. Then clinical presentation and diagnosis, field criteria and comments. Demographic data age should be more than 40 years. So what happens, I must say, what happens in Indian where the population is in developing country, mostly people are labor class. Labor class person generally earn 1,000 rupees a day, and in which they spend about 200 to 250 rupees in alcohol, and 50 rupees, that is not mentioned here, and 50 rupees in smoking. Alcohol means BD or cigarette. And I must tell you, cigarette is more harmful than BD. So what happens when a laborer or who earns 1,000 rupees per day, he spends 250 or 300 rupees in the evening before going to home, and he goes to home in a drunken condition, and he don't give money to his wife or children, and he beats, and that is usual process. And I must say this smoking and alcohol is very common in higher class and lower class, and in middle class usually the students of college or the executives of multinational companies who work late in the evening and late in the night, they do smoke, do take alcohol, and their lifestyle is bad. So they suffer from asthma and chronic bronchitis and emphysema or ACOS, and they also have cardiac condition. Recently, 10 days back, my intern student got this fainting attack in hostel. This is real fact in Maharaja Agrawal Medical College hostel. an intern student who was in NRI, he fainted in the hostel, and on examination he was found to be suffering from a coronary artery disease, and he developed thromboembolism, and the embolus went into the upper story, and he was paralyzed left sided, and he was shifted from our college to a private nursing home in Hisar, and from Hisar to Delhi, and it was not controlled. From Hisar he was put on ventilator, and he was operated in Medanta Hospital, Praniotam. And I don't know what is his fate now. He is still unconscious. So anyhow, that was by the way. So demographic data is age 40 years, medical history, a documented asthmatic history before the age of 40, prior symptom of asthma or allergic rhinitis, history of atopy or allergies, more than 10 packs of tobacco smoke. So I must say smoking and alcohol. These are the two. And thirdly, this drugs in Punjab, chitta. These three, and fourth, of course, the lifestyle and other things. These are the things which cause most of the lung and heart diseases. Then the symptoms, the frequency, intensity and duration of respiratory system symptoms, then exercise limitation. We don't have say exercise limit. All things are controlled by remote. Even fans and lights are controlled by remote. People don't move from the bed. So respiratory symptoms like dyspnea, including exertional dyspnea, cough, sputum are persistent, but variability in symptoms may be prominent. And then spirometry, of course, we do for obstructive and restrictive lung disease. Then clinical presentation and diagnosis, field criteria comments. So lab test we do, lab test may we do serum IgE level. If it is more than 100 international units, it goes in favor of asthma or COPD. Then secondly, eosinophil level. It should be usually, it is usually less than 300 cells per liter, per microliter. If it is more than 300, it means there is atopy or allergy. And we have seen many cases in which the absolute eosinophil count is in thousands, say to the tune of 2000 or more. Then third is alpha-1 antitrypsin deficiency. Then imaging, usually in X-ray chest, usually is helpful in diagnosis a case of asthma or chronic bronchitis or emphysema. Otherwise, further we can go for axial tomography. If there is diagnostic uncertainty, we can go for computerized tomography. Then coming to the non-pharmacological treatment. Non-pharmacological treatment, the first and more foremost is smoking cessation. So in the morning session we were seeing the obese person, then Manjaro injection that causes smoking and alcohol, uski इच्छा ही नहीं करती. So that is very important. Then vaccination. Besides the vaccinations of children, say infant or say under the age of 5 years, we can go for adult immunization also, say annual influenza vaccine or pneumococcal vaccine. Then allergen avoidance. It is very difficult to go for allergen avoidance in a developed country. In developing countries. In developed countries there is good atmosphere, but here it is where say there is air pollution by vehicles, and in rural area there is ladies working in chula, so they get smokes. Of course now the cylinder have come by this government. Then inhaler technique. Inhaler technique, I would like to say inhalation is much better than giving oral drugs and injection, because by inhalation, by inhaler, there is less side effect of drugs. Then pulmonary rehabilitation is given by physiotherapist. Then pharmacological treatment can be divided into 4 group echoes A, B, C and D. They are shown in the diagram, although the letters are not clear here. So in echoes A, there is stage 1, there can be low medium dose of ICS. ICS means inhaled corticosteroids. Then stage 2 is LABA, and the stage 3 is triple therapy, means inhaled corticosteroids, LABA, LAMA and LABA, LAMA and inhaled corticosteroid, ICS. Then again group echoes B, this is more serious type of asthma. Here low medium dose of inhaled corticosteroids plus LABA or stage 2 triple therapy. In group echoes C, directly we have to go for triple therapy. Say this is a ascending type of treatment. In group echoes D, stage 1 LABA and LABA and stage 2 triple therapy. This all depends upon the severity of symptoms, whether we have to go for echoes C, echoes B, echoes C or echoes D. This all we have already discussed. Then there are some biological agents which are helpful, new drugs which can be given in case of asthma or chronic obstructive lung disease or combined echoes. These are omalizumab, is difficult to pronounce, benralizumab, maprolizumab, rezulizumab, dopilumab and tazepilumab, different types. So there is a need of future research in echoes, asthma, chronic obstructive lung disease, to better understand echoes and its treatment. Further investigation is needed. This is a burning topic and scientists are trying, and this further investigation is needed to identify the types of biomarkers and phenotypes that can identify patients who are most sensitive to particular therapies. Current research on echoes traits has not utilized all possible classification methods. Longitudinal studies are required to enable a deeper understanding of these phenotypes and how these influence management decision. In addition, performing detailed research including respiratory microbes could considerably improve phenotyping. So conclusion is, asthma and COPD have characteristic symptoms. As I defined earlier, asthma, chronic bronchitis and emphysema separately, yet patients with both are prevalent in the society. However, there is no globally accepted definition of echoes, and it may not be considered as a distinct disease or clinical entity. Some people say echoes, some people say no. So debate is still going. Beside the age and the smoking history of patients, recurrent pulmonary infection, as I told you, bacterial infection like streptococcus and other, inflammation have been considered as provoking factors contributing to the worsening of pulmonary function in elders. No single biomarkers can be used to identify and classify echoes phenotypes. Then non-pharmacological treatment option for the echoes patients include smoking cessation, number 1. Then number 2, annual influenza vaccination. Number 3, pneumococcus vaccination. Number 4, inhalation techniques. So many, say inhaler coming, budamate, say budamate and glycohale and so many, duolin. So they can be given in morning, evening dose or combined dose depending upon the severity of infection. Then you have to avoid the provoking allergy factor. And lastly, pulmonary rehabilitation. The treatment of echoes tend to be escalated to counteract the clinical manifestation and prevent further worsening. We have to control it and stop it there. This may involve increasing inhaled corticosteroids using dose of LABA and LAMA.